Okay, moving into anaphylaxis. Anaphylaxis is basically a systemic allergic reaction. Okay, it's not just focused like an asthma is based on the lungs, but this is basically some kind of allergen that is affecting all of all the body systems kind of pretty much at once. Okay. So I want you guys to keep in mind that not all coughing, wheezing, and dyspnea are due to asthma. It could be because of an anaphylactic reaction. This will cause severe acute respiratory distress. Some patients that do have a history that they know that they're allergic to something do carry an epinephrine autoinjector, which you guys are allowed to administer to your patients. The autoinjectors go into the lateral anterior portion of the thigh when we're given it. And there is a skills video, I believe, of how to actually administer an autoinjector. You're basically going to hold it against the thigh. You're going to press the button. You're going to hold it there for about 10 seconds to make sure that all the medication is expelled out of the autoinjector. And that's how you guys actually give the epinephrine to your patient. If your patient does not have the epinephrine or epinephrine autoinjector on them, then you guys are allowed to pull up epinephrine 0.3 milligrams via a limited dosing syringe. Okay, you can only give it through a limited dosing syringe, and then you guys can inject it either into the anterior lateral thigh or into the media deltoid of the left or right arm, like you would any other intramuscular injection. Okay, so what's going on with anaphylaxis? First off, I want you guys to understand that anaphylaxis is a form of shock. Okay, it is something that we do deal with quite a bit in EMS, and basically this is an antigen antibody response. Okay, so I'm going to use for an example a bee sting. Okay, somebody gets stung by a bee. That bee releases a toxin into the body. The body sees this toxin as a threat. It develops antibodies to the antigen. The antigen is the venom or the toxin that is released from the bee. The antibody is basically the chemical marker of the body saying, hey, if we see this again in our body, I do not like it. We are going to attack it. Okay? So the antibody is a protein produced by the immune system in the response of an antigen. Make sure you guys know the difference between those. The antigen is the irritant. The antibody is what fights that irritant. So really what happens is when we do suffer an allergic reaction, we have things in our body known as mast cells. And it's actually mastulin cells, which means feeding cells. So basically what happens is when we are exposed to the antigen, okay, our antibodies kind of go along and try to pick up or collect all the antigens, all right? These antigens are attached to mast cells, okay, at first, before the antibodies come. These mast cells are actually mistakenly believes, right, that they are they release these granules to nourish the surrounding tissues. Okay, this is the body's natural response, also known as a histamine response. This is where your histamine comes from, or from these mast cells. These play a key role in the inflammatory process. And this plays such a key role, and they are so efficient at doing this, that the inflammation process can become overwhelmed and can actually lead to an anaphylactic reaction. Once you guys start moving up in level of licensure, you guys will be able to give Benadryl. Benadryl is one of the main drugs that we give for allergic reactions, and basically the Benadryl goes around and it blocks these mast cells from bursting, releasing their granules, and causing the histamine response. Okay, so again, some anaphylactic triggers. Could be foods, medications, latex allergies, and insect stings seems to be the most common in our society. I also want you guys to know that you guys can develop an allergy to anything at any point in time in your life. This isn't something that we're born with. You guys can be eating strawberries, loving strawberries, and then one day you guys are not allowed to eat any more strawberries because for whatever reason your body saw something in those strawberries as a threat. They saw those strawberries as an antigen, and because of that, your body developed antibodies so that the next time that they see this antigen show up, they're going to attack it, right? So basically, it's like the strawberries entered the wrong hood, right? They're in the wrong hood. They're about to get their butt whooped, and that's what the antibodies do for us. We really, really, really need to make sure that we gather a good sample on our patients as soon as we can in order to identify if they are or have the potential to be allergic to something or a procedure that we might be doing for them. When we're discussing anaphylaxis signs and symptoms, remember that anaphylaxis is a form of shock, and we're going to talk about shock later on. But usually, when we're dealing with some kind of anaphylaxis, it usually occurs right around 30 minutes or sooner after the exposure to the allergen. And it really kind of depends on the patient and how their body has actually responded to the antigen before and how many antibodies the body has actually developed in order to fight that antigen when the body is exposed to it. The big clues for anaphylaxis is the hives, or what we call urticaria, and those are kind of blotchiness on the skin. They look like these little kind of pinkish or purplish welts all over the body. That's what we call hives. It's also known as urticaria, and they could have swelling. And the big swelling that we're worried about is what we call angioedema. Angioedema is usually found in the mouth, and when we have swelling in the mouth, specifically the tongue, we are having a severe airway problem. If we're swelling up that tongue really doesn't have any other place to go but out the mouth and to the back of the throat, which can completely occlude the airway. So when we're dealing with anaphylaxis, it is definitely important to make sure that at the basic level we are getting paramedics or at a very minimum intermediates there in order to be able to provide IVs for fluid replacement. Plus they also have a couple extra drugs that you guys cannot play with in order to help stop the swelling and inflammation process that's going on in the patient's body. They will have respiratory distress. They could possibly have wheezing. And then they could also have stridor. And stridor is a very high-pitched kind of whistling sound. That is the only upper airway adventitious sound that I'm holding you guys to this semester is stridor. And that's basically your throat is actually closing off, right? So you guys are not able to get the air in and out of the lungs due to the swelling that's being caused in the actual throat itself. Hypotension, we're going to talk about low blood pressure when we specifically talk about our shock lecture. Hypotension is the first true sign that the patient is not compensating anymore for the shock that they are experiencing. So as soon as we see drops in blood pressure, more than likely we are starting to kind of fall behind the 8 ball. We're going to have to start getting a little bit more aggressive to our treatment, and we'll talk about that more when we actually talk about the signs and symptoms of shock itself in our shock lecture. And then, of course, altermentation. They can become irritable. They can become confused. They can become restless, trying to find that position of comfort for them, no matter how they're sitting, whether they're sitting or laying or standing up. They're just really kind of antsy. They can't really kind of focus on what's going on. So those are your classic signs and symptoms of anaphylaxis. This picture here is a picture to show you what urticaria actually looks like. Remember that urticaria is also known as hives. You guys can kind of see how There's redness in some areas, and then there's these kind of blotchy, kind of pale spots, basically from head to toe. You can really see it in the right arm there. No, that is not a farmer's tan. Okay, you can also see it on the left butt cheek, kind of going down the left leg there as well, and then throughout the back. This is a classic presentation of hives. It can be much worse than this, but this is pretty a mild form of hives. Not saying that hives is put a distinguish on hives as mild or moderate or severe. If we see hives, more than likely we are definitely 100% dealing with an allergic reaction, possibly even going straight into anaphylaxis, which is a systemic allergic reaction from head to toe. This is a great picture of that systemic head to toe urticaria for you guys. This is by far something where you guys would definitely want to consider giving epinephrine right off the bat through the IM. If they have an auto injector, you can assist them with their auto injector for epinephrine as well. But this is something that we would want to go straight to epinephrine for. Here's a picture of angioedema. You guys can see how swollen this little guy's lips are. You can actually kind of see the urticaria as well. You can see those little kind of red blotches on his chest and his shoulders. His face is flushed, but we are concerned about the angioedema with this. Due to the swollen lips, I would assume that underneath those swollen lips, that tongue is starting to get pretty swollen as well. And this is also probably something else that should hopefully put the scare of whatever believer you guys believe in on. We really need to make sure that we are securing a good patent airway. This slide I kind of put on as a comparison, so you can see in the upper left her normal everyday self. The bottom left is when she was kind of basically in a full-blown allergic reaction. You guys, if you can see the redness around the eyes. She does have some redness along her throat as well. We would also be concerned about airway on this patient due to the fact on how the urticaria is kind of on her face. We always, again, plan for the worst and hope for the best, so we would hope that that tongue is not swelling too much. And then the picture on the right of this lady here is actually after treatment. This is after she has received epinephrine. She did get one shot of epinephrine. She was also given a albuterol and ipratropium together, duoneb. And then this is where you guys can kind of see how that swelling kind of goes down. You can still see, however, that kind of urticaria. It does take some time. Just because you guys give epinephrine right off the bat doesn't necessarily mean that urticaria is going to completely go away instantly. All we want to see with the epinephrine basically is we want to make sure that that urticaria is not spreading systemically, right? So we still see the urticaria. It could take hours, it could take days to go away for the urticaria to actually disappear. But I just want you guys to know that it's not really that obvious, even after treatment of anaphylaxis, that urticaria is going to completely go away instantaneously. Here is a classic picture of angioedema. That tongue is obviously extremely swollen. However, I want you to kind of look at this patient, right? Taking the big picture of this patient. First of all, you can see that she is already in a hospital setting. Her tongue is extremely swollen, right? But really, if you look at it, that's really all that is going on with our patient. She's alert, right? She's looking at you guys. She's staring at you guys. She's posing for the picture, if you would. Her skin color, based on her ethnicity, looks pretty good. Maybe her family might say she's a little pale, but she looks a little good to me. And really, the only thing that we're seeing is the swollen tongue. We're not seeing any kind of urticaria around her neck or face, or going down her into her shoulders. I mean, obviously we can't tell much by this picture, but the good news for this lady is that if that tongue is swelling, which it obviously is, it's swelling forward. It's not necessarily swelling towards the back of her throat, occluding her airway, because she is still alert. She still has good skin color. This is actually a picture of a lady that was prescribed a new blood pressure medicine. That blood pressure medicine was known as lisinopril. It's a very common blood pressure medicine that's out there. And unfortunately, sometimes people can be extremely allergic to lisinopril, and we won't find out until they actually take the medication. So, fortunately, this little old lady had a new prescription. The medication didn't work out the way it was supposed to. She did end up having an allergic reaction. However, this is more of a localized allergic reaction and not a systemic. And it just happened to be localized right there in her oral pharynx, specifically making that tongue swell up. So this is just kind of some examples for you guys on what kind of things you might see when somebody is suffering from an anaphylactic reaction, whether it be systemic or whether it be local. The big thing when it comes to anaphylaxis, or really shock in general, is that all three of the big three systems are affected: the respiratory, cardiac, and your central nervous system. Specifically with anaphylaxis, we get massive amounts of airway swelling, and I've already showed you guys some examples of that. We can have both the wheezing and or the stridor. Remember, wheezing is in your lower airway. You're going to hear that basically in the patient's lungs. And then the stridor is going to be in the upper airway, which is kind of like the actual throat, and the back of the oral pharynx is actually swelling, and it's starting to prohibit air movement from coming in and out of the lungs. When we're talking about the cardiovascular system, our cardiovascular system is going to start kind of running on overdrive because we're not being able to process the air that's moving in and out of our lungs effectively. We might not be able to get the air in and out of our lungs effectively. In turn, the brain's going to start getting upset, and it's going to make the heart start pumping faster in order to try to move the red blood cells that are already being oxygenated through the lungs as much as possible. And we're going to talk about redistributive and hypovolemic shock during a later lecture. And then the central nervous system, if this does become systemic and we are having systemic problems from head to toe, our brain's going to start getting upset. It doesn't really realize what's going on. It can actually start shutting down certain organs in our body. And because it's shutting down those certain organs, it's going to start going into a altermentation, decreasing the level of consciousness, or what we call as LOC, in our patients due to hypoxia, which is lack of oxygen to the brain, and the fact that the brain is not getting the oxygen that it needs for energy because of the poor perfusion due to the fact that our airway is swelling, that we can't get the air in and out, the good air in, the bad air out, and it's going to continue to do this until, unfortunately, we either intervene and recognize this, or our patient passes away. So what do we do for anaphylaxis? Well, we have to be able to recognize it first and foremost. That is that's the big thing. We definitely want to make sure that even though their airway is kind of shutting, we want to make sure that we are providing oxygen, usually from a non-rebreather, right around anywhere between 10 and 15 liters per minute. I would like to go big on this, so I'd like to get 15 liters per minute, just to try to saturate as many red blood cells with oxygen as I can. We definitely want to transport quick, guys, okay? We want to get off scene. There's not much that you guys can do at the basic level for this. So really the key is to actually recognize this first off and providing high flow oxygen. And we're going to talk about the treatment of shock later on. But we want to make sure that if there was some kind of injection mechanism, such as if they were stung by a bee or stung by a wasp or something like that, right? Some kind of scorpion. We want to make sure that the actual stinger is not still present in the patient. Okay, this is huge, guys. This means that you're going to have to go and kind of look over every square inch of this person's body in order to see if we find a stinger. If you do find a stinger, and please pay attention to this because this is a test question. If you guys do find the stinger, you want to go with the grain and remove it with a credit card, okay, or some kind of hard plastic device, okay? You just don't want to pull it out. We want to try to pull it out the same direction that the actual stinger went in to the patient. And the best way to do that is go with the grain of the stinger and pull it out real quick. Just slide a credit card right over to get that stinger, or some kind of piece of plastic, in order to get the actual stinger out of the patient. If they are in severe respiratory distress, you guys are seeing head to toe urticaria, they have a high heart rate, they have a low blood pressure, absolutely your first line of defense is a shot of epinephrine. Okay, your epinephrine is 1 to 1,000, 0.3 milligrams, either sub-Q or IM. I'm going to suggest going IM on this one, all right? And you are technically supposed to call an MSEP. And remember that the MSEP stands for Medical Control Emergency Physician. Don't wait, okay? Sometimes you guys can be trying to get a hold of an MSEP, and you call the hospital, the hospital which the patient would like to go to. You're going to call the doc or the MSEP in that emergency room and ask for permission to give epinephrine. But if you can't get a hold of that doc, like literally right away, okay, guys, just give the shot of epinephrine right off the bat, okay? No doc is ever going to say, hey, how dare you give epinephrine, right? In this case, epinephrine is a life-saving drug, all right? Let's give the shot of epinephrine, and then really quick, followed by albuterol, right? A nebulizer of albuterol, in order to try to prevent the swelling from happening even further. At which point, hopefully, you guys are already transporting your patient either to the hospital or rendezvousing with the ALS/ILS unit. But make sure that you guys do get that epinephrine on board quick, followed by that albuterol nebulizer, in order to try to open up the airway as best as possible for our patients.